I can't anymore go down a tube. I can go on the underground as long as the train doesn't stop too long, but I can't go in the actual Piccadilly tube, that sort of tube. I can't get into a small lift or a lift, or if the train stops or the lift stops, there's immediate panic. Social occasions give me great trouble because I usually try and avoid them. That's dinners and parties especially. Dances I can't attend at all. For some reason or I just won't go, which is very troublesome for the family in some ways. They don't understand it and think I should just ignore it, but I just can't do it. And in fact, I've several times had to, I've been booked in for perhaps a quite important lunch in business, not lately, this is some time ago, and on 3 occasions I was booked in and got as far as the front door and turned around and walked away, and I just couldn't go in. I think that's the basic thing. I'm now beginning to find that driving is becoming, I don't enjoy driving, but that may be just a question of age, I don't know. I think the general, I get nightmares. I don't get nightmares so much now, but originally after, I suppose for years, every now and then there'd be the most violent nightmare, and I'd be wake up shouting and screaming, and my wife would wonder what was going on. They gradually died down after the years, and it doesn't happen much now. Unless occasionally I get a bad night, and something is usually because there's something going to happen the next day. And it's all rather sort of feeble, and it doesn't, one gets aggravated with oneself, really, for having these sensations, I suppose. You try to do this under, the climatic conditions were really against you, in Burma anyway, and you just try to do it, and it would be, you'd be doing that during the day, and you'd be on guard at night, and that sort of thing. It was all rather monotonous, if you like, in some respects, as it went on and on and on, and it never seemed to end. But of course it did end quite well.
The main phenomenon that we're interested in the military, amongst military personnel engaged in disaster work or indeed engaged in a wartime situation, is battle shock. Battle shock is defined as a temporary psychological disorder experienced under severe battle conditions where there's been much bombardment and many casualties. We are interested in that because we believe, if correctly recognized and correctly managed, that something in the order of about 70 to 80% of those cases can be turned around and sent back to the front line, where they're likely to remain effective for a period of about 7 days. Now, we believe the same might well apply in a natural disaster situation, that if we're in a position to intervene at an early stage, when I say we, the psychological service, are in a position to intervene at an early stage and begin this early management task, this early supportive task towards helping those people to come to terms with their experience, then relatively few of them will go on to develop the complications of the disaster setting or the war setting, amongst which are the whole range of psychological disorders, but one of which is this phenomenon known as post-traumatic stress disorder. The range of psychological reactions seen in people who have witnessed or have been involved in a major disaster, whether it's natural or man-made, vary from the acute anxiety state, which is quite understandable, into conversion, hysterical conversion phenomena, into fugue state, into frank psychiatric illness, precipitated psychiatric illness. The majority of cases are going to be people experiencing what can best be described as a normal reaction to an abnormal event. And our task, as far as possible, is to try and normalize that and help them to accept it as normal and use the appropriate normal strategies to handle the normal phenomena, such as anxiety, sleeplessness, anger, tearfulness, alcohol abuse, smoking to excess, drinking too much coffee, all these sort of normal reactions that people display when they've been very upset. The thing to emphasize about post-traumatic stress disorder is that it isn't a new phenomenon. What is new about it is its description. But if you actually look back over the history books, you'll find people like Samuel Pepys, who experienced the Great Fire of London, or Charles Dickens, who was involved, we're told, in the first fatal railway crash. With hindsight, they were describing the phenomenology. And the phenomenology essentially follow on the exposure to an event that is outside the range of normal human experience, in which there is intrusive thinking and about the events experienced, and an avoidance, if at all possible, of any stimuli that are likely to remind you of that horrific experience, with the appropriate autonomic arousal, the sweating, the palpitation, the anxiety, the depressive mood swings. Those features come into it. And we believe that if we are in a position to mobilize the appropriate resources early on, we can prevent a significant development of this post-traumatic stress disorder. It needs to be emphasized that in the process of developing post-traumatic stress disorder, people go through what is considered to be a normal phase, and by definition post-traumatic stress disorder can't be said to be present unless the symptomatology has remained for a period of at least 1 month, 28, 30 days. What is of interest too, of course, about post-traumatic stress disorder is that some people who appear to have escaped in the aftermath of the disaster and subsequent screening appear to have escaped any significant psychological reaction when subsequently examined. A proportion of those, about a third, are identified as suffering from what was called late onset post-traumatic stress disorder.